Good day. Here is a rationalization for our ASO quiz. There were 35 items. There were 35 questions, 20 of which were administered to you during the quiz. But for this rationalization, all of the 35 items will be explained. For the first item, in ASO testing, what serves as the antigen? In ASO latex agglutination, the purpose of the test is to detect the presence of ASO antibodies in patient sample. ASO antibodies are directed against the streptolysin O antigen. In ASO testing, streptolysin O antigen synthetically coats the carrier particle, which is in the form of latex particles. Latex particles coated with anti-streptolysin O is not the correct answer because, again, we are to detect anti-streptolysin O in patient serum. So the antigen here is streptolysin O antigen that coats the latex particles. What type of agglutination is ASO latex agglutination? We have already discussed this, that ASO latex agglutination is an indirect agglutination. Indirect agglutination is also known as passive agglutination. This is referred as indirect agglutination because the antigen here, which is in the form of streptolysin O antigen, is synthetically incorporated to the carrier particle, which is in the form of latex particles. It is not direct agglutination because direct agglutination uses antigens that are naturally incorporated to the carrier particle. But in the case of ASO, the antigen, which is the streptolysin O antigen, is synthetically incorporated to the carrier particle, which is the latex. This is not heme agglutination because there is no involvement of RBCs. For this question, I've told your professor to make this a bonus because I have discussed in ASO testing that, well, the preferred sample for ASO testing for serologic testing is of course serum samples. But plasma samples may be used. But if we are to use plasma, the most appropriate anticoagulant to use should be heparin. So for this item, the possible answers are serum samples and heparinized plasma. What is the best course of action when there is anticipated 24 hours delay in testing? Of course, when there will be delay in testing, it is necessary to store samples. Storage may be done in refrigeration at 2 to 8 degrees Celsius or freezing at negative 20 degrees Celsius. Now, for the choices that you were given, to freeze serum samples, refrigerate whole blood samples, incubation at room temperature. None of the choices. We are not to incubate the sample at room temperature because antibodies will degrade rapidly when stored at room temperature. So it is important to store either at freezing temperature or refrigerator temperature. Now, between freezing serum samples and to refrigerate whole blood samples, the best answer is to freeze serum samples. Why? Because class we are not to refrigerate whole blood samples. RBCs may hemolyze during the process of refrigeration. And remember that hemolyzed samples are contraindicated in any serologic testing. So we have to separate the serum sample first. Then the serum sample will then be subjected to refrigeration or to freezing. So among all the choices, to freeze the serum samples is the best answer. Now, what is the expected positive reaction in ASO testing? Of course, the positive reaction is agglutination or clumping or agglomeration. Um, Double band or line in the C and the T regions, this is when we perform immunochromatographic assays, such as those in pregnancy test kits. Color change may also be done in serologic testing, but color change is more common in chemistry testing when we perform spectrophotometric analysis. How should we report samples that yielded positive in the qualitative testing? Our keyword here is qualitative testing. When the test is qualitative, we are to report the result either for ASO qualitative testing, we are to report the result either as positive or negative. Most of you answered reactive, but reactive is not the appropriate term. It should be positive. Okay? Some of you also answered titer, which is in TOD or IU units, But the keyword kasi here is qualitative. We only report titer when we perform semi-quantitative or quantitative. Okay, so the best answer here is none of the choices. What is a diluent to use in making reagent dilutions for semi-quantitative ASO testing? Class, when we perform semi-quantitative ASO testing, we perform dilutions, and the diluent that we use is saline buffer solutions or normal saline solutions or physiologic saline solutions, depending on what is incorporated in the reagent box. But for this question, the keyword here is reagent dilutions. Class, please remember we do not perform reagent dilutions. Yes, we perform dilutions of the serum samples, but not of the reagent. Okay, I hope that's clear. So the best answer here is none of the choices. For this question, you are given with five tubes, and tubes 1, 2, 3, and 5 gave a positive reaction, whereas tube 4 gave a negative reaction. This question was not discussed to you in the lecture because the purpose of this question is for you to incorporate your learning in week 1, which is preparation of dilutions, and the current lesson. Okay? Now, as a review, it was discussed to you by Mambea during dilution, as the dilution increases, the concentration of the target molecule decreases. Okay? Let me repeat that. As the dilution increases, the concentration of the target molecules decreases. So in this case, tubes 1, 2, 3, and 5, it is expected that tube 1 is the most concentrated and tube 5 is the least concentrated. Okay? Now, tubes 1, 2, and 3 gave a positive reaction. Tube 4 gave a negative reaction. Tube 5 yielded a positive reaction. Now, you have to observe tube 4 and 5. How come that there is a positive reaction in tube 5 and there is no reaction in tube 4? It is expected that tube 5 has lesser concentration of the antibody than tube 4. So if agglutination is seen, it should be on tube 4 rather than on tube 5 in this case. So if this is the scenario that was given to you, you can say, class, that something is wrong in the setup of the medical technologist. Because if, sorry, because, because something is wrong in this setup because tube 5 should not yield a positive reaction if tube 4 yielded a negative reaction. It may be that tube 5 is contaminated or if tubes 4 and tubes 5 were interchanged, no? Now, if that's the case, the best thing to do is to repeat the entire testing process. We do not report if discrepancies are encountered, and more so, we are not to open a new box yet, no? Kasi when kung ma-remember ninyo sa flow chart of resolutions when discrepancies will be encountered, if you are to encounter a discrepancy, the very first thing that you do is to really report the entire testing setup using the same box of reagent. Okay? So for this question, this will be answerable by going back to the flow chart that I have presented to you. So again, this is a discrepant testing. So the very best thing to do is to repeat the entire testing. Now, what is detected in ASO testing? I have discussed earlier that we are to detect anti-streptolysin O antibodies in the patient serum sample. Now, during a semi-quantitative ASO testing, the following results are obtained. What is the titer? Now, kindly observe tubes 1, 2, 3, 4, and 5. Tubes 1, 2, and 3 yielded positive reaction. Tube 4 and 5 yielded a negative reaction. It is also stated that controls yielded the expected results. Therefore, the entire testing is valid and streptolysin O standard is used. Now, when we are to obtain the titer, we have to get the dilution of the last tube that yielded the positive reaction. In this case, it's tube 3, and the dilution of tube 3 is 1:4. And then we are to get the reciprocal of this, which is 4, and we are to multiply by the dilution factor or the sensitivity factor, which is 200 IU per ml or 200 TAD units for ASO. So 4 times 200, that will be 800. But class, the keyword here is streptolysine O standard, and I have discussed to you that if the standard used is streptolysine O standard, the result must be reported in exactly TOD units. If the WHO international standard is used, that is when we are to report the result in IU per ml. So in this case, since the standard use is streptolysine O, therefore the results must be reported in TOD units. So the answer is none of the choices. Okay. Which of the following organisms induce the production of anti-streptolysine O? Of course, it was discussed to you. It's Streptococcus pyogenes or group A, strep. Which of the following is true about rheumatic fever? Okay, rheumatic fever is a post-streptococcal sequela. In rheumatic fever, there is involvement of cross-reacting antibodies. Okay, please, this choice is not the correct answer because in rheumatic fever, what is involved is cross-reacting antibodies. It's not cross-reacting antigens. Okay, so this choice is not the correct one. There is deposition of streptococcal antigens in the heart muscles, which causes an immune reaction, resulting to destruction of the heart muscles. Um, there is no deposition of the streptococcal antigens. Rather, there is deposition of streptococcal antibodies. Okay? So this is not also the correct answer. Patients experience joint pain. Yes, the reason why this is called rheumatic fever because the patients experience fever and also joint pain. Okay. Streptococcal infections can cause sequela such as, of course, the two typical sequela of post-streptococcal infection is acute glomerulonephritis and rheumatic fever. It's not rheumatoid arthritis. Rheumatoid arthritis, that is an autoimmune mechanism. Scarlet fever, it's not because it's not a sequela. Scarlet fever is a manifestation of a streptococcal infection but not a sequela. And the same thing with necrotizing fasciitis because necrotizing fasciitis is also a manifestation of a streptococcal infection and not a sequela. Which of the following is our mode or modes of transmission of group A Streptococcus species? Group A Streptococcus species are natural inhabitants of our respiratory tract. Therefore, they can be transmitted via droplets, coughing, and sneezing. Group A Streptococcus can also cause skin infection. So if we have direct contact with an open wound infected with group A Streptococcus, then that is a valid and possible mode of transmission. What is the organism screened in ASO testing? Of course, that is Streptococcus pyogenes. Which of the following conditions are caused by group A Streptococcus infection? Okay, the question here is you are asked of the conditions that may be caused by group A Streptococcus. Either it is a current condition or a post condition or a sequela of the condition. So scarlet fever, yes, this is a manifestation of a group A infection. Acute glomerulonephritis, yes, because this is a sequela following group A infection. Rheumatic fever, yes, because this is also a sequela. Necrotizing fasciitis, because this is a manifestation of a group A streptococcus infection. So these four are the possible answers. In streptococcal acute glomerulonephritis, what mechanism is involved in the development of the disease? It's immune complex deposition. Antigen antibody complexing has been deposited in the glomerulus of the kidneys, and the immune complex deposition there causes the activation of the immune system antibodies are activated, the complement system is also activated, causing destruction of the glomerular cells. Cross-reacting antibodies is true for rheumatic fever. Direct injury caused by the presence of the organism. This is not the correct answer because remember, acute glomerulonephritis is a post-streptococcal sequela, meaning this condition will result following or after a Streptococcus pyogenes infection. So in this case, the organism is no longer present. The next, time and speed of mechanical rotation in ASO testing. Rotation may be done manually for 2 minutes or through subjecting it to mechanical rotation for 2 minutes at 100 RPM. In ASO testing, the visible agglutination is because of, okay, the correct answers here are cross-linking of antigens and antibodies. Class, when cross-linking of the antigens and antibodies occur, this is visualized as agglutination. And of course, if there is the presence of the target antibodies in the patient sample, a visible agglutination will also be observed. The presence of target antigens in the patient serum, this is not the correct answer because in ASO testing, we do not detect antigens in the patient serum. And there is no antigen in the patient serum. Which of the following is true about direct agglutination? So again, as I have mentioned, direct agglutination includes antigens that are naturally found on the surface of the particle. Example, in your RBC, RBC contains antigens such as type A antigen, B antigen. So those antigens are naturally found on the surface of the RBC. It involves reaction of particulate antigen with its corresponding antibody. This definition is a definition of agglutination in general. Agglutination occurs when there is an interaction between a particulate antigen and its corresponding antibody. Now, direct agglutination, it is not called heme agglutination because agglutination can only be called as heme agglutination if it includes RBC. But in this case, the question is merely direct agglutination. So this is not a possible answer. An example is ASO testing. This is also not the correct answer because ASO testing involves passive or indirect agglutination. In post-streptococcal acute glomerulonephritis, damage to the glomerulus is because of, okay, again, as we have mentioned, acute glomerulonephritis post-streptococcal acute glomerulonephritis involves antigen-antibody deposition in the glomerular tissue. When antigen and antibody complexes are deposited in the tissue, there will be activation of our immune system. Complement proteins will be activated in order to eliminate the antigen antibody complex. Likewise, phagocytic cells will also be activated to eliminate the antigen antibody complex. Cross-reacting antibodies, this is not the answer for acute glomerulonephritis because cross-reacting antibodies attacking the structurally similar M protein is the mechanism of rheumatic fever. Okay? Structurally similar M protein in the myocardium. Okay, that is the mechanism for rheumatic fever. So this is the mechanism that I have discussed to you in the lecture. So complement proteins will be activated when there is deposition of antigen-antibody complex. Likewise, your phagocytic cells will also be activated. These phagocytic cells will phagocytize and will remove the antigen-antibody complex. Now, in the process of activating the complement and the phagocytic cells, there is a collateral damage induced to the glomerular tissue. Okay. What is the purpose of the latex particles in the reagent? So we know that for latex agglutination testing, the latex particles here act as a carrier of the streptolysine O antigen. Okay, take note ha, the purpose of the latex particles is it acts as a carrier for the streptolysine O antigen. It does not act as the carrier of anti-streptolysine O because latex acts as a carrier of streptolysine O antigen. It indicates a positive reaction. This is also not the correct answer because a positive reaction is indicated by exactly agglutination. It makes the testing easier to perform. Not necessarily. And this choice here is actually a vague statement because um, to make something easier is a subjective matter, 'di ba? What might be easy for you may not be easy for me. Okay? So the best answer here is none of the choices. Now, which of the following tests can be requested by the physician to detect post-streptococcal infections? Okay, the keyword here, class, is post-streptococcal infection. So when we say post-streptococcal infection, the infection is already done. There is no more bacteria present in the system of the patient. So during a post-streptococcal investigation, the best test to request here is to detect for the presence of antibodies. We cannot perform bacterial culture here because most probably we will not be able to isolate any organism. And detection of streptolysin O in patient serum. This is not the correct answer also because in post-streptococcal infections, most probably there is no longer presence of, um, there is no more antigen present in the patient sample. So most probably we will not be able to detect streptolysin O in post-streptococcal scenarios. So the best answer here is anti-DNAs. Anti-DNAs is an antibody produced during streptococcal infection, and we can detect the presence of these antibodies even after streptococcal infection. So this item is a bonus item, but before we proceed to that, let us first discuss the question, the item. Which of the virulence factors is used by the organism to establish deep tissue infection? So our keyword here, class, is deep tissue infection. Now, if you can remember in the virulence factors of the streptococcal species, M protein is found on its fimbriae, and fimbriae is used by the organism to adhere to the epithelial lining. So it is used by the organism to initiate infection. Capsule is used by the organism in order to evade the phagocytic activity of our WBCs. So, hindi sila napaphagocytize because they have the capsule. Now, this question is a bonus question because the correct answer here should be hyaluronidase instead of anti-hyaluronidase. Hyaluronidase because if you remember in your biochemistry, hyaluronidase is an enzyme, and the substrate of hyaluronidase is hyaluronic acid, which is found in our connective tissue. Now, in the presence of hyaluronidase, hyaluronidase will break down hyaluronic acid of our connective tissue, and that will allow the organism to establish a deep tissue infection. So it will try to damage our connective tissue so that it can dig deeper and can burrow deeper in our tissues. So again, this question is a bonus question, but if you will be asked if you will be asked what are the virulence factors of the organism in terms of invasion, okay, so you have the hyaluronidase together with the DNAs also. Okay, let's proceed. During testing, you noticed that there is agglutination in the positive and negative controls. Which of the following is the best course of action? So, for this question, the keyword here should be is agglutination in the positive and negative controls. We have discussed that your negative and positive controls are used during testing for quality control check. Now, the positive control should yield a positive reaction, which is agglutination. The negative control, we should expect that there will be no agglutination in the negative control. But in this case, both positive and negative controls have agglutination. So that means that this is a discrepant testing. Now, if you remember in the flow chart of how to resolve whenever discrepancies will arise, the very first thing you do is, of course, to recheck the box if the reagents are contaminated or if the reagents are expired. But initially, checking should be done prior to performing any testing, no? Nagpe-perform lang tayo ng rechecking of the reagent box for signs of contamination and expiry to make sure that what we used during testing are reagents that are stable. But anyway, after you have rechecked the sample, the box, you are first going to repeat the entire testing. Class, this is actually true in chemistry, in hematology, in serology, no, that even in parasitology and in urinalysis, no, urinalysis, particularly when we use machines, no, that whenever we perform any tests or any methods or diagnostic methods, if we ever encounter any discrepancies, the very first that we have to do is to repeat the entire testing. So when we say repeat the entire testing, repeat testing the controls, positive and negative, and you repeat the entire batch of patient specimens in the testing, no? We are going to duplicate our testing because probably in the first test that we did, maybe the reason why there was a discrepancy was because maybe there is an error in the pipetting of the medtech, or there may be contamination between the reagents or between samples and reagents when placed in the slide. So, mga ganon. No? So, to make sure and to validate that what we did at first was truly a discrepancy, no? And to make sure that we did not incur any error during testing. So that is why we have to repeat the entire testing process. But if during the repeat testing we still encounter the same discrepancy, that is when we are going to open a new box of reagent. So we are going to open a new box of reagent because probably the previous box that we use is already contaminated or the reagents have already degraded. Remember that reagents become unstable once they are opened, even if we store them properly. But storing them properly will help to preserve the shelf life of the reagents. It's just that there will really come a time that the reagents will degrade. No, so by opening a new box, then we can ensure that the reagents that we are going to use during the testing are new and therefore no signs of contamination, no degradation. Now, and then after opening a new box, then we have to run another testing again. Okay, so I hope that's clear. Now, when we perform repeat testing, we have to repeat everything. Again, let me repeat that. Everything must be repeated and not just merely the positive and the negative control. Okay? You have to repeat the entire testing, including running or including testing of the specimens of the patients. Our next case involves 8-year-old Joshua who goes to the hospital because of a fever and chest pain, a positive heart murmur, and fluids accumulating around his heart. His history revealed a scarlet fever 3 months ago, so the doctor suspects rheumatic fever. The doctor ordered two ASO tests. Results came, the first with a titer of 300 IU per ml and the second ASO titer is 650 IU per ml. Before we proceed, allow me first to correct myself regarding the reference range that I gave you for ASO. Um, I've told you that the normal reference range for children for ASO titer is 240 to 640 Todd units. These values are actually the values for anti-DNAs. Please correct on your notes. 240 to 640 Todd units is a reference range for anti-DNase titer for children. The normal value for children for ASO titer is less than 100 Todd units. Again, normal value for children ASO titer is less than 100 Todd units. No? Therefore, the significant titer for ASO in children is 100 TOD units, greater than 100 TOD units. For adults, it's greater than 200 TOD units. Okay, please, I'm going to repeat. Normal reference range for ASO titer for children is less than 100 TOD units. The normal value for ASO titer in adults is less than 200 TOD units. The 240 to 640 TOD units is the reference range for anti-DNAs. Okay? Okay. Now, for our case, Joshua here had a scarlet fever 3 months ago, and currently he experiences symptoms that are consistent with rheumatic fever. Now, why is it rheumatic fever? Given the history of Joshua and these manifestations, these are consistent with rheumatic fever. Now, but since the doctor is not yet sure if this is a rheumatic fever, hence he ordered ASO test. The ASO testing will help diagnose or will help to confirm his diagnosis of rheumatic fever. But in this case, I've presented two ASO testing, one with 300 IU per ml, the first result, and the second with 650 IU per ml. Now, if you can observe, there is a twofold increase in the ASO titer of Joshua. Now, I have mentioned in the lecture that a twofold increase in the ASO titer is diagnostic for streptococcal infection. Okay? Let me repeat that. If you can remember, a twofold increase in the ASO titer is diagnostic for streptococcal infection. Okay? Now, um, I would like to explain the mechanism involved why there has been an increase in the antibody titer. This was actually asked by one of your batchmates. Now, the reason why there has been an increase in the antibody titer, we can trace that back in the kinetics of antibody production during streptococcal infection. This graph here will tell us the increase or the values for the antibody titer during the course of a streptococcal infection. Now, in the early phase of the infection, about 1 to 2 weeks following the onset of the infection, there is not much antibody produced, okay? But 3 to 4 weeks after the onset of the infection, that's when there will be a peak in the antibody production. And a week after the peak, around 5 weeks following the onset of the infection, there will be a decrease in the antibody titer is expected. Okay? Again, let me repeat that during the early phase of the infection, the antibody production is starting to increase around 3 to 4 weeks following the onset of the infection. There will be a peak in the antibody titer, and 5 weeks onwards, there will be a decrease in the antibody titer. Now, what is the significance of this value, or what is the significance of this fact? Now, in this case, I gave a scenario of a two ASO testing, and the ASO testing, the two ASO testings, there is a twofold increase. There is a twofold increase on the second ASO titer. Now, this result class is significant such that this is diagnostic of an active or a very recent streptococcal infection. Okay, let me repeat that. The twofold increase in ASO is diagnostic for a streptococcal infection. So, we can say in the case of Joshua, yes, he had a rheumatic fever as a complication of his past infection, and concurrently, he also has an active streptococcal infection. And why were we able to say that he had a concurrent streptococcal infection? That is um, the evidence for that is due to the twofold increase in his antibody titer. Okay, I hope that's clear. Now, As for this question, what does the result say about Joshua's condition? And since the doctor is suspecting of a rheumatic fever and then he had an increased antibody titer, then the results support the diagnosis of the doctor of a rheumatic fever. Okay? And the it may be added it may be added in the diagnosis that Joshua also had a current active streptococcal infection. Okay, I hope that's clear. So again, let me make emphasis, okay, for diagnosis of streptococcal infection using antibody titer. Okay, applications na ito, class, ha, how we can interpret antibody titers in the diagnosis of streptococcal infection or the diagnosis of post-streptococcal sequela. As for infection, when a single test is done, elevated levels may suggest the infection, but a single test warrants additional tests for confirmation. A single test may only be done in endemic areas where there is outbreak of streptococcal infection. When such when that is the case, there is an outbreak, then a single positive test is already significant for streptococcal infection. But in cases where there is no outbreak, there must be two testing to do. Okay? Dalawang test dapat. And then there must be a twofold increase of on the antibody titer of the second testing. So similar to the case of Joshua, he has first 300 IU per ml, and then on his second test he had 650 IU per ml. So there is a twofold increase. Then therefore that is diagnostic for a streptococcal infection. Okay? Now, for confirmation of post-streptococcal sequela, what doctors do is correlation, no? Doctors correlate clinical manifestations together with elevated ASO titers. As for confirmation of post-streptococcal sequela, one testing is already enough. Okay, one testing, one antibody titer result is already enough, given that the antibody titer must be higher or elevated than the normal, no? So the doctor will correlate the symptoms, signs and symptoms of the patient plus an elevated titer, so that is already diagnostic for the sequela. So in the case of Joshua, he has the symptoms, signs and symptoms of rheumatic heart fever. And then he had an elevated titer. So that is already diagnostic for rheumatic fever. Okay, I hope that's clear. So for our next question, what are the reagents typically included in ASO test kit? Of course, the reagents are ASO reagent and control reagents. Distilled water is not included in the reagent kit. Disposable slides and disposable stirrers are included in the test kit, but they are not reagents. Okay, they are materials to use during the testing. They are not reagents. So the answer here are ASO reagents and control reagents. If you were able to read the package inserts that I have sent you, no, ito yung typical content of an ASO test kit. In ASO reagent, sodium azide is used as, I have included this in your reading assignment. Yes, sodium azide is used as a preservative. Again, the source of antigen for ASO testing is streptolysin O antigen coating latex particles. Okay? The latex particles will act as a carrier of the antigen. Sodium azide is not the carrier of the antigen, it is the latex particle that acts as carrier of the antigen. Reagents must be stored at refrigerated temperature. It is also included in all test kits on how to store the reagents, and it is important to follow proper storage of the reagent to lengthen the shelf life of the reagents. As I have always repeat uh, that reagents degenerate rapidly once they are opened, once the seal um, was broken. So you have to store those reagents properly to avoid um, degeneration of the reagents. What is the purpose of the WHO international standards or the streptomycin O standards? That is also included in your reading material. The standards are used for calibration. Now, don't worry regarding these standards and calibration. You will have a deeper discussion on this on your clinical chemistry, particularly in the concept of quality control and quality assurance. So in all testings, in most of the testings that we do, including chemistry, even in HEMA, and here in serology, we use standards for calibration. Okay? And please remember that if the reagent uses WHO international standards, the result must be reported as IU per ml. And if the streptomycin O standard is used, the result must be reported in exactly, Todd units. Okay. What are you going to expect with 10 minutes rotation on the slide? The rotation must only be within 2 minutes. If it is done with mechanical rotator, that should be 2 minutes at 100 RPM. Then after that, the slide should be read right away because if there will be a delay in the reading of the results, that will cause a false positive reaction. That even though there is no agglutination, drying of the reagents may cause false agglutination. So that will give a false positive reaction. Agglutination reaction so far is the only known methods for ASO detection. A positive reaction in ASO qualitative testing has a minimum antibody titer of 200 IU per ml. The first statement is wrong. If you have read the reading materials that I have given you, those those were two package inserts. The first package insert employs latex agglutination, whereas the second package insert uses immunoturbidimetric method. Okay? So if you read that, you will be able to answer this. A positive reaction in ASO qualitative testing has a minimum antibody titer of 200 IU/ml. Yes, 200 IU is the minimum limit of detection in ASO testing. So if the antibody titer is higher than 200 IU, you will always expect that a positive reaction may occur. But increased antibody titer at some point only because antibody excess will yield a false negative reaction. And you will have a detailed explanation on that on your finals when you will discuss serologic methods on particularly in agglutination. So again, for this question, the first statement is wrong and the second statement is true. So, if you read also the package insert, and then this table here is found in the package insert. So, this is the minimum limit of detection. So, there is no dilution here. So, this is a positive reaction with no dilution. So, that gives a minimum of 200 IU per ml. 200 IU per ml again is the minimum limit of detection for ASO testing. In ASO testing, the stronger the agglutination, the higher the antibody titer. A negative ASO testing is indicative of a negative streptococcal infection. Okay, for the second statement, as I have mentioned earlier, that there is about 15 to 20% chance of a false negative reaction. Only 80 to 85% of individuals in the population will produce anti-streptomycin O antibody. Now, the 15 to 20%, they may not produce ASO antibodies, but it doesn't mean that they did not have streptococcal infection. Okay? So, that 15 to 20% accounts for a false negative result. In ASO testing, the stronger the agglutination, the higher the antibody titer. At some point, yes, that when there is increased antibody titer, it may yield a stronger agglutination. But only to some degree, only to some extent of antibody titer. Why? Because if there is antibody excess, it may result to weak reactions. Okay, please take note of that. When there is antibody excess, that will yield a weak reaction or a false negative reaction. And you will have a more detailed explanation on this in your lecture finals for serologic techniques. An antibody excess may produce weak agglutination. The reagent sets a 1 month allowance past the expiry date. For testing in the laboratory, when it comes to reagents, no, walang allowance. Okay? Kasi very critical ang mga reagents once they are opened. There is only a particular period for their shelf life, and if the reagents are expired, we are not advised to use expired reagents. No, that is why it is important that before doing any testing, you have to check for the expiry of the reagents. Because if the reagents are expired, it will yield either a false positive or a false negative results. An antibody excess may produce a weak agglutination, as I have mentioned earlier, that weak reactions may result when there is antibody excess. No? So that's it. That ends our rationalization for ASO quiz. I hope you were able to take note the explanations presented to you. Thank you so much for your time and for listening. Have a good day.